Aloha, everyone, and welcome to the Department of Geriatric Medicine Grand Rounds. Before I introduce our speaker, we have a few housekeeping items. This CME activity is sponsored by the Hawaii Consortium for CME, which is a joint venture between the Hawaii Medical Association and the John A. Burns School of Medicine, University of Hawaii. At this time, please enter the name and credentials of everyone viewing Grand Rounds for CME attendance purposes. Please enter that in the chat box. As a reminder, evaluations are required for CME. You can find the evaluations by following the link in the chat, or go to our website, or go to our email advertisement. Your comments are very important in the planning committee and will be used to plan future programs. So please give us comments. As you know, all sponsors of CME are required to execute a conflict of interest policy. Speakers are expected to disclose to the audience any real or apparent conflicts of interest. Dr. Raman has disclosed that he has no relationships with commercial supporters that could be perceived as a conflict of interest for this presentation. It's my great pleasure to welcome Dr. Raman. He was born on the Caribbean island of Trinidad. He attended Morehouse College in Atlanta, Georgia, and medical school at the University of the West Indies in Trinidad. He then did his surgical residency at Oregon Health and Science University and did his MBA in healthcare management also at OHSU. He has served in various roles, such as medical director, department chair, and medical chief of staff at the Samaritan North Lincoln Hospital in Oregon. Most recently, he joined the VA in January 2021 as Associate Chief of Staff overseeing geriatrics, rehabilitation, and extended care. Welcome, Dr. Raman, and thank you for talking to us on this important topic of surgical considerations in the elderly.
Good afternoon, Dr. Masaki, and good afternoon to everyone. I appreciate the intro and happy to be here. Happy to give you guys a little bit of a talk on surgical considerations in the elderly. So I'm going to go straight into this, and it looks like my screen is working well. So if you guys have any audio or visual issues, let me know. So as Dr. Misaki mentioned, just in terms of disclosures, yes, I do like pina coladas and getting caught in the rain, and I have no financial disclosures for this presentation today. And as mentioned, currently my title is Associate Chief of Staff for Geriatrics, for Rehab, and for Extended Care at the VA Pacific Island Healthcare System. And I am a board certified general surgeon, and that's obviously something that if there are questions about that as well, let me know at the end. We can talk about that. But I mention that specifically because, and I say this to the medical students and the residents specifically, you know, as professionals, we aim not to, we have to be professional and definitely, do not make fun of your colleagues. Do not crack any jokes about your colleagues, but it's okay to crack jokes about yourself once in a while. And I'll do that. I'll crack a joke about myself and my surgical specialty. There's many jokes, but the one specific one I'll tell is the joke about the surgeon and the internist in the elevator, and the elevator door is rapidly closing, and somebody down the hall is shouting, "Please stop, wait, hold the elevator." And the surgeon and the internist, both trying to help that person, decides to find a way to stop the elevator. So the internist puts his hands out, and the surgeon bends forward and puts his head out to stop the door from closing, which the joke being what's important to each of those. So cracking a joke about myself and cracking a joke about surgeons, we sometimes get the rap that we think we're the smartest people in the room, but we know we're not. And I do have a lot of respect for the internal medicine subspecialties. The difference between the two, I would think, between the surgeons and the internists and the subspecialties in internal medicine, has to do with my memories of a med student and being asked questions by my professors. And I remember Dr. Maria Bartholomew, our internal medicine professor, when she asked us to name the causes of name the top 20 causes of a GI bleed, you'd start off with gastritis and peptic ulcer disease, duodenal ulcers, gastric ulcers, diverticular bleeds, esophageal varices, angiodysplasia, AVMs, and you go down the list, and you would have to get to 20 for her. Like you would have to get to blue rubber bleb syndrome and chicken neck syndrome or pseudoxanthoma elasticum and all those things to really impress her. And again, surgeons, we're really not that smart. We really focus on maybe three things. So if we ask you what's the causes of acute pancreatitis, we just want you to say gallstones, alcohol, and idiopathic, and boom, you've hit 90%, and we're happy and we move on. So for the purposes of this presentation, we do have some key learning points, and I am going to touch on all of these. I don't necessarily want you guys to write these things down, but it's a lot. It's a lot to digest looking at that one slide. So let's condense it down to just maybe two things. I am going to talk about some preoperative concerns and how we manage that globally. And we are going to talk a little bit about goals of care in the surgical patient and what that means. And if you want to even distill that even more, just to one sentence, what I would like us to walk away from at the end of this talk, this conversation between us, I don't want to use the word lecture, is really just to highlight salient management strategies for aged surgical patients to achieve optimal care and reduce postoperative complications. So if there's one sentence that you walk away with in terms of what we're going to look at, that's kind of it from here. 5 parts to what we're going to talk about, and the first part being general considerations. I loved putting these slides together because the stuff that we're going to be talking about in this first part is the stuff that I think everyone who's logged in to listen to me could probably teach me about. One of the things I regret in hindsight is that we probably in surgical residency didn't get any we really didn't get enough geriatrics influence in terms of our teachings. And it really would have been nice for us to have in our grand rounds, once or twice a year, to have a geriatrician come across and talk to us. Because as surgeons, we think that we're going to be operating on these 20 and 30 and 40-year-olds. But the data shows that we have an aging population. Again, you guys know this in great detail. Between 2000 and coming up very close to 2030, we're going to have a doubling in our population of 65-year-old people and above. And in terms of actual numbers, that is going to be roughly 70 million people, or 1 in 5 people by 2030. And most of the people who are alive today are going to be alive in their 9th decade. So surgery is a geriatric subspecialty to some degree. And we talked about this as a chief resident and as a young attending, that a lot of our patients are actually geriatrics patients. And we weren't quite prepared for that as medical students or junior residents in surgery. And the reason that is so important is because these patients represent a unique surgical challenge due to the complexity of the comorbid conditions that they have, coupled with the physiological changes that occur with aging. Over half of the patients in this 2011 study, so 10 years ago, over half of the patients that were looked at were over the age of 65, and flipping it around as well, about half the population of people over the age of 65 will require surgery once in their lives. So again, surgery is becoming more and more of a geriatrics overlap. And the thing that I don't think was taught well to me as a medical student is how important physiological age was as opposed to chronologic age, and some of the discussions that we have with surgery, with morbidity and mortality. It is a pretty accurate predictor of postoperative morbidity and mortality. And physiological age specifically being a measurement of the level of development, health, or deterioration of an individual in terms of functional norms. It's something that I think we've talked about in the surgical subspecialty more in the last 20 years, but it really wasn't something that we talked about when I was a medical student. I'll give a couple quick examples. Mrs. Smith is someone I remember very, very well, because I saw her, I would say, probably recently in 2017, 2018. she was a 94-year-old who was referred to the general surgery clinic for anemia, and her PCP, left an urgent message for my nurse, and Cheryl called me and said, "Oh my gosh, we've got this 94-year-old who's got a hemoglobin of 6." And the first thing that went through my mind is, I knew what my patient population was, and I've got debilitated 50 and 60-year-olds or 70-year-olds. So, gosh, is she in a nursing home? Please make sure she doesn't just come with her kids. Make sure she comes with her grandkids, so that, because her kids are probably in their 70s. Do I need to go make a home visit, or what's the scenario with this patient? Either way, let's get her in quickly. So we scheduled her for a next day appointment. And in walks in Mrs. Smith, uh, um, who drove herself to the clinic, got a couple pints of blood. She got 2 units PRBCs in the infusion clinic down the hall, and walked over to my office. Gave me a good handshake. Talked to me in detail about how at 94 she's retired from taking care of her husband's business. She was the bookkeeper up to the age of 92 when he passed away, and she's a little bored, but because she's not doing any more bookkeeping, but she still gets up and she walks around, and she has no difficulty going up a flight of stairs or walking a block. That's not an issue for her at all, except for her knees. And went into great detail in terms of what she does in terms of her day-to-day activity. Totally threw me off in terms of how well she presented, based on the kind of patient population that I was used to. And we had a conversation for colon cancer. So at 94, you start off with a conversation saying, the average person between 50 or 45, now that we've lowered our age for colon cancer screening, 45 and 75, the risk of perforation is about 1 in 1,000. The risk for death is about 1 in 100,000. But one of the reasons we stop around 75 in terms of colonoscopies for colon cancer screening is because we start to see increases in the risks and complications of colonoscopies and obviously surgery. So that's part of the equation. What do you want us to do for you? And she was adamant. I'm 94, but I intend to live to 100, and my parents lived to over 100. So yeah, let's do something about it. So she asked for the colonoscopy. She got it. This is not her actual image from our colonoscopy. It's another patient of mine, but I didn't have hers to put on this. But she did have a colon cancer that she wanted surgery for, and we were a smaller hospital. We didn't have a pulmonologist and cardiologist nearby, so I sent it to one of my colleagues 30 minutes away, and she had a lap sigmoid colectomy and did well. So remember, it's easy for us as surgeons to forget that there are patients that meet this physiological well-being, even though their chronological age is something that might initially scare us. And quickly, I'll also tell you about the 84-year-old gentleman at Oregon Health and Science who we did a kidney transplant on. And this is a gentleman who, uh, while in the military, uh, was shipwrecked and held onto a rock for 2 days until he was rescued. And while he was on post-op day one, walking around the unit with his IV pole and storming around very proudly that he could get up and walk with after a major operation like a kidney transplant, we had another patient who was a 30-year-old or 32-year-old kidney donor who had a very minimally invasive procedure who couldn't get up. So physiological health is really important when we start talking about surgery in the elderly. Um, the physiology of aging, frailty. This is something else that was not discussed when I was a medical student, and has become a critical part of surgical discussions. Um, we're not where we need to be in surgery in terms of discussions with frailty, and I do think we need help from the geriatric subspecialty to kind of bring us into the 21st century with respect to this. But it's important that this be mentioned as part of our assessment, because we do assess frailty in the office preoperatively. Frailty syndromes being associated with advanced age that results from decreased physiological reserve and makes patients less resistant to major stressors such as invasive surgical procedures. These are patients who are going to be at risk for falls, to getting up out of bed, for moving around after surgery. So everything from atelectasis to DVTs to PEs are going to be increased in these patients. They're going to be at higher risk for ICU, delirium. They're going to be the ones who are going to be higher risk for discharge to skilled nursing facilities postoperatively. The reason why this is really important from a surgical perspective to talk about is because patients and their families should be warned prior to going to the surgeon and at the surgeon's office as well about the risks that they have, the elevated risks that they have in terms of being frail. And frailty scores, there are multiple different types of frailty indexes and scores, but frailty scores are an accurate representation of the patient's physiologic age. It's important to recognize, even though as geriatricians, you all talk about frailty quite a bit, it's important to recognize this is very, very new to the surgical community. And even though your surgeon is going to have an understanding of what frailty is, your anesthesiologist, your pre-op screening nurse who's going to be calling you for some questions or calling the family may not have a lot of information or understanding of what frailty means or how it overlaps with the surgical intervention that patient's going to have. And it's okay to remind them that frailty predicts disability, but disability may exacerbate frailty, which also leads to co-occurrence and difficulty in assessment of frailty in of itself. So when having those conversations with the surgical teams, I think it is important to bring up any concerns with frailty that the patient might have as you're referring that patient over and starting a conversation in terms of surgery. And as I mentioned, there's lots of different ways to measure frailty. And as surgeons, we take into consideration a lot of these factors. We take into consideration the cognitive ability of the patient when we're talking to them in that preoperative visit. We absolutely look at their nutritional status and their hemoglobin. All of those things that we do. I don't think we're at the point in the surgical field where we have a widespread acceptance of calculated frailty scores and indexes, but it's something that we do subconsciously in terms of taking into consideration a lot of these factors. So everything, again, from nutritional status, physical activity, strength, cognition, mood, disability, general health, all of those things factor into our decision making when we're planning surgery for a patient. And these objective measures that formulate frailty and frailty scores have been shown to predict 6-month postoperative mortality. They're very, very good measures. Surgery in the elderly. This and the next topic is really where the meat of the matter is going to be in terms of some of the stuff that I am going to talk about and stuff that I enjoy talking about. So elderly patients often present with atypical symptoms. We all know that. And especially with abdominal exams, they can be misleadingly benign appearing. And I'm sure you all have seen cases of that, but I'm going to get into a little bit in terms of the specifics. Acute appendicitis, acute cholecystitis, very common abdominal conditions that occur in adult patients and the elderly. And a delay in diagnosis or a misdiagnosis could be catastrophic. Let me go into more detail. Let's take appendicitis. For the medical students and for the residents, when we talk about appendicitis, you'll see lots of different symptoms and signs that will associate with appendicitis. Fever does not happen in a lot of patients. Leukocytosis, in the average adult patient, over 10% of them are not going to mount a white count in the first place. In the elderly, that could go up to about a third of patients. So really, pain and some anorexia, those are really the most consistent findings in even the 20-year-old or 30-year-old or 40-year-old. So your 80-year-old is not going to present with typical symptoms of appendicitis. Peritonitis. Again, just kind of poking at the med students here for a second. Remember you've got your two layers of your peritoneum, and this classic periumbilical abdominal pain that goes to the right lower quadrant in appendicitis. It's really from initially your visceral peritoneum getting irritated first by this ugly little irritated appendix, followed by the parietal peritoneum afterwards, and that results in that periumbilical pain that moves to the right lower quadrant. All of those things that are described as classic are things that you may not or likely will not see in the geriatric population. And the reason why is important is because there's so much misdiagnosis. Again, here the initial diagnosis is correct in less than half of these patients. What happens is a significant change in the perioperative management of these patients, and as I mentioned, their morbidity and mortality. So, for example, in terms of the specifics for acute appendicitis versus ruptured appendicitis, if I operated in any of you, y'all came in today and we say, oh my gosh, you've got acute appendicitis. I would take you to the OR. We'd do a laparoscopic appendectomy. We'll take out the appendix. You would get no postoperative antibiotics. You would get some Jello and whatever you want to eat for dinner tonight, whatever you feel like, and you go home in the morning. And I'm conservative. I'd keep you overnight. There are some surgeons who would send you home the same day. If you perforate with acute appendicitis, 24, 48 hours later, undiagnosed, and the patient perforates, then you go from a overnight stay in the hospital, going home, eating whatever you want immediately after surgery, to maybe 5 days in the hospital, IV antibiotics, concerns for maybe up to a 40% chance of pelvic abscess development a week or two down the road. So significant morbidity, significant mortality changes with something as simple as that, and with a misdiagnosis. And again, even with a microperforation, there is that increased risk of pelvic abscess. So you may not know anything. You may send the patient home, and they come back to the surgical clinic because a week later they've developed this pelvic abscess, which means multiple procedures and maybe some percutaneous drainage and so forth. So these late diagnoses or misdiagnoses do have a significant impact in terms of what happens next with the patients. Biliary tract disease is actually the most common indication for surgery in the elderly. And again, a delay in diagnosis in these patients could lead to sepsis, whether it's from ascending cholangitis or gangrenous, breakdown of the gallbladder with perforation, gallstone ileus. All of those things are pretty common. The good news is, we have moved into some more non-invasive or less invasive ways of managing gallbladder disease, appendicitis, even diverticulitis in the elderly, in the adult population in general. Funny enough, that actually comes from data from the pediatric population. So putting a perc drain in, sticking a drain in someone's gallbladder, easy to do for a radiologist and CT guided, ultrasound guided. You can get a patient, an 80-year-old with who's hypotensive, floridly septic, white count 18, platelets dropping. Just take them to the radiology room, have the interventional radiologist stick a drain in, relieve the pressure on the gallbladder. You can quickly get that adult patient, that elderly patient, that ICU patient, quickly get them better. So fortunately, we don't have to rush to surgery. But again, the diagnosis and having that early diagnosis is important. If there's one, I told you the one sentence I wanted you to remember in terms of what we were talking about. If there's one image I want you to remember, it's the red box in the middle. Because once you have a patient who has a need, and between the geriatrics department and the surgery department, there's a discussion about whether or not the patient is an acceptable surgical risk, the investigations that you need to do, and I say you, I mean the medical teams, both medical and surgical, the investigations that need to be done, that 5 points in that red box is really kind of a significant conversation piece for the surgical team, the anesthesia team, and the geriatrics team. And I'll explain why in the next few slides. But while the anesthesiologist and the surgeon to some degree is going to be moving forward with any additional investigations for this patient, it is critical for the geriatrics um, uh, team, the medical team taking care of the patient, to not only uh, identify some of these things preoperatively, but also make sure it's documented and communicated to the teams effectively. And I'm thinking of this Swiss cheese effect that we have in terms of errors that happen. The fact that surgeons and anesthesiologists are notorious for wanting to just go in and get everything done quickly and leave. The onus is on them to do a thorough history, physical, and investigations. But I think we can close some of the holes in that Swiss cheese if there's good communication between the primary team and the surgical team in terms of some of these issues, so that we are aware and we can assess and factor in those details. Because if those patients don't have a physiological reserve, or the quality of life cannot be maintained after we've gone through all of the all of those assessments, then it really affects our ability to provide a definitive surgical intervention for patients. So one quick high point from what we talked about in terms of abdominal disease: please have a high index of suspicion for abdominal disease in the elderly. I know as geriatricians, you deal with a lot of non-specific pains, and there's a lot of constipation issues. There's a lot of gastritis. There's a lot of other things that affect patients in terms of their non-specific abdominal pains. But remember that there's a lot of pathology that can happen that may not be presented in a typical way. So what happens when you actually do have to send this patient off for an operation? Classically, we did everything open. The surgeon in Germany in 1985, I believe, 1985, who did the first lap chole, was chastised by his colleagues, saying that only someone with a small brain would do an operation with a small incision. And he was laughed at, and they actually tried to take his medical degree, medical license away from him, having done 100 successful lap choles. We like to do things open because it's usually faster, and we get patients out of anesthesia time pretty quick. But what happens is we make a big incision. Depending on their nutritional status, that's higher risk for infection. They're going to have more pain because of the bigger incision, which means they're going to take more time to get out of bed over the next couple days as opposed to right away, which again, reduced mobility puts them at risk for DVTs and PEs. Yeah, the medical students will again, they will remember that the most dependent space when someone is supine is the hepatorenal space of Rutherford Morrison. So Rutherford Morrison's pouch. So you get blood collecting at and around the diaphragm, below the diaphragm. That it irritates that. It stimulates more pain. They're not going to breathe well. They're going to splint, which increases their risk for atelectasis, which then increases their risk for pneumonias. So all of these, maximally invasive operations, these open surgeries, tend to increase hospital stay, increase postoperative care, increase the need for rehabilitation, and perhaps institutionalization afterwards. So you're going to see more and more laparoscopic surgery happening for the geriatrics population. I mean, we do this for pregnant women now. It's not a big deal to go in and do a lap apnea or lap chole and take out someone's gallbladder or appendix when they're pregnant. We have determined safe ways to do that now. Likewise, you're going to see more and more laparoscopic techniques used in the elderly to reduce the risk of atelectasis and GI disturbance, wound infections, and all of the things that I just mentioned. So what do? We put them to sleep. We introduce carbon dioxide into the peritoneum. We elevate the pressures in the peritoneum to, usually it's about 15 or 20, 15 to 16 millimeters of pressure, and kind of tense it up. Literally you get this tenting effect, so you can beautifully see inside with your camera. But being a first-year medical student, I was wondering, why do we have to learn Starling's law, and why do we have to learn all of this stuff? I want to be a surgeon. What's this preload and afterload and contractility issues? Well, just a good reminder: as you increase those pressures, you're putting pressure on the IVC, and that decreased IVC pressure decreases your preload. So in your patients with cardiac issues, you're decreasing your ventricular filling pressures, you're decreasing your cardiac output. So we are cognizant of that when we're taking patients to the OR, and this can be life-threatening in patients with pre-existing cardiac dysfunction, poor functional reserve. The other thing that I do want to throw in is uh, that studies have demonstrated that both advanced age over 70 and ASA classification of 3 or 4 are associated with higher rates of conversion from laparoscopic gallbladder surgery to open gallbladder surgery. So all of those things do factor in when we're making decisions about how to take care of these patients and their surgical issues. Cancers. This is becoming obviously more and more the reason why we're operating on these geriatric patients. We have increased life expectancy coupled with increasing incidence of cancer with advancing age. There's a lot that is going on with respect to geriatric oncology and surgery in the elderly. And I'm happy to maybe talk about that at the end if people want to talk about it a little bit more. But I would say, especially in the rural populations, because most surgeries are happening, more and more out in the rural areas because of the booming populations of these rural areas. We're going to see more and more rural cancer surgeries happen as well. And over 50% of those diagnoses are going to be made in patients 70 years or older. And you can see that when you look at CDC data, clearly that distribution curve on the left of new cancers, over 50% of that is going to be in the 70 plus age group. Again, a reminder for the residents and for the medical students, in terms of cancer deaths, for males, you really are focused on the top 3, which is lung, prostate, colorectal. For female, you're focused on lung, breast, and colorectal. That's your quick answer when you're asked the question, name the top 3 causes of cancer deaths in males or females. When you combine the two, you're going to get lung is number 1 and colorectal is number 2. The important thing to remember is a lot of these cancer diagnoses, if caught early, are treatable and sometimes curable. Stage 1 breast cancer, for example. Stage 1 breast cancer has an over 95% cure rate. Stage 1 colon cancer has a almost 95% cure rate. So early detection and early management of these cancers are really critically important. And there's I think it's quite understood and quite seen that we're really undertreating the geriatric population for curative resections in cancers. There's a lot of patients that may not get referred or may meet a surgeon who's reluctant, maybe because they have not had much experience in operating in geriatric populations. So there is concern that maybe, are we really doing all that we can for these patients as they get to 70, 80, or 90, in terms of at least having the discussion, far less the actual surgical intervention for some of these curative resections. And this is where it becomes complicated. Clearly, it's not easy. It's that conversation about having the surgery to improve life expectancy and not decrease life expectancy or quality of life. And that's where the complications obviously come in terms of how to figure out what's right for each individual patient. We know that some of these potential reasons for these quote unquote under treatments, maybe because of poor functional status compared to younger patients, or family preference or patient preference. But this is part of where we need to be better in terms of the conversation between primary teams and surgical teams. This is an interesting graph. This shows what the referral rates are to oncological surgeons based on age. And you see that as patients get past 80, there's a pretty steep decline, and this includes potentially resectable lesions. As I said, my 94-year-old, she did well after having her sigmoid cancer removed. I operated on a 85-year-old retired nurse who had similarly had sigmoid colon cancer. It was through, I think it was Christmas of 2017, I believe. Healthy, had a couple comorbid issues, was obese, was diabetic, but she did great. And the chronologic age as opposed to the physiologic age is something that I'm glad to see surgical specialists kind of move away from. But I think making sure that we have appropriate referrals and not forget that some of these patients may very well do well after surgery is important. And this goes back to the algorithm of if if the patient's life expectancy is greater than their cancer survival risks, and they're not frail, and we've had a good discussion in terms of informed consent, where benefits are better than risks, then yes, let's go ahead and operate on them and actually deal with the underlying pathology in a surgical manner. So as we start to have more and more of these conversations, we get into the ethical considerations of what are we doing for these patients. We have increasing effectiveness of modern therapies. We have more intensive care. We can put people in intensive care. Pre-COVID, we could put people in intensive care scenarios for long periods of time and keep them alive. And basically, we're sustaining life, or as I like to tell some family members, we're sometimes prolonging death. So we need to have really good communication, not just between the teams, but with family members in terms of what our goals are and what we're trying to do, and to make sure that we're not going down the road of medical futility or just doing a surgery for the sake of doing a surgery. And I know I'm being a little bit contrarian here in terms of please refer more patients to surgery. Please, have high suspicion for intra-abdominal issues, but part of what we do as a surgical team is try to assess in terms of is this going to cause more harm in the long term to the patient than not. And that's something that a good surgeon will really take the time with the family to have those discussions and hash that out. What some of you guys might know is prior to 2014, any patient who had a DNR, you know, you might have had a long conversation with the family, you might have had a long conversation with the patient, him or herself, and they said, "Doc, I don't want anything done for me if my heart stops or if I stop breathing." If they get sent to the operating room, and this is prior to 2014, if they got sent to the operating room across the country, the ORs would have a policy to hold the DNR. And I'm not sure exactly why that originated. It could be a combination of anesthesia saying, well, we're giving medications that's clearly going to affect the heart and lungs, and we can rapidly reverse it if something happens, if someone has an arrhythmia, or it could be something along the lines of hospitals or physicians did not want a death recorded in the OR or on a surgical team's count, for reporting purposes. I don't know why that was the case, but in 2014, the American College of Surgeons put out a really interesting white paper in terms of requiring reconsideration. And hopefully, when all of you who are practicing talk to your surgeons, hopefully we don't do this anywhere in the country anymore. Hopefully, since 2014, 2015, 2016, most places would have stopped that cessation of the DNR or the hold of that DNR. They should be doing what's called a required reconsideration, where if the patient has a DNR, the surgeon and the anesthesia team is supposed to go back to that patient and say, "Hey, I know we're just doing this quick colonoscopy or this quick upper endoscopy. The risk's extremely low, but if you were to die on the table, would you want us to do anything for you in terms of trying to bring you back. And respecting the patient's autonomy and respecting the patient's wishes, because forcing them to have CPR and forcing them to have a held DNR is no longer acceptable in the surgical community. So I struggled a little bit with the 5 hospitals that I worked with in my system to try to get this changed, and we did. It took about a year and a half to get this changed in at least 4 of the hospitals in terms of the required reconsideration. But please take into consideration that if you're dealing with someone who has been operating for a long time, or a hospital that may not have made any significant progress in this, please advocate for your patients in terms of having a required reconsideration of the DNR, and not automatically holding it in the OR, i.e., not automatically ignoring the DNR that you may have discussed with your patient. So again, the surgeon, the anesthesiologist, the team, they're supposed to discuss the goals of care, figure out, if we're going to do an investigative procedure, then why are we doing it? Is there going to be definitive management afterwards? What's the patient's code status? What do you, sir, ma'am, what do you want us to do if something happens to you? Would you like us to respect your DNR that you have in file, and make sure that the advanced directives and power of attorney information is easily accessible to the team? So surgeons and anesthesiologists, again, are notorious and stereotypical for just wanting to get in and get the work done and get the job done. If there's one area that I think we really need to do better as surgeons and as anesthesiologists, it's in this aspect of geriatric patient care, in terms of taking the time to go through the chart and speak to the patients in this. So one of the things that you all can do as primary team members is make sure that this is effectively communicated to our surgical teams. And then we get to the preoperative assessment. So that big red box that we talked about, I'm going to touch base on some of these things now. So surgical risk increases with age, and part of that has to do with the patient's development of comorbid conditions as they get older. And a more detailed preoperative assessment is really needed in this geriatrics age group. Big slide, busy slide. I'm going to cut it in half just to make it easier to read. So the ASA physical status classification. Again, I'm sure the medical students are all excited because they know all about this, but I am going to touch base on it just for a minute. In the geriatrics patient population, I'm not sure what your distribution is in each of your practices, but I would imagine the majority of them are probably ASA 3s. You probably have some ASA 2s, and then probably the smaller groups would be 1s and the 4s. So what's an ASA 3? A patient with severe systemic disease, a patient who has 1 or more moderate to severe diseases. So poorly controlled diabetes, hypertension, COPD, patients who have alcohol dependence or abuse. Clearly, this is the majority of patients that are in the, at least, looking at the CLC type patients, these are our patients. These are typically ASA type 3. The reason why I'm putting this slide up, even though it's an anesthesia preoperative assessment, is because the geriatrician being aware of where the ASA is and what the medical conditions that are not well managed are, will help us reduce our postoperative complications, our intraoperative and postoperative complications. And the reason that is because your ASA classification is a really good guide as far as who's going to have complications. Easy number to remember is number 5. So why am I calling out 5? Is because your ASA 3 patient, your patient who has moderate to severe medical conditions, they're going to have a 5 times odds ratio for medical complications. Or if you flip it around, they're going to have a 20% or 1 in 5 chance of a complication. So, and you can see, if they go from an ASA 3 to an ASA 4, they go from an odds ratio of 5 to 17. So being aware of that, managing those diseases well preoperatively, if you have time, if it's not an emergency, if it's an elective procedure, really getting good medical management and communicating some of these issues with the preoperative team or the operative team would be good at helping reduce the chance of this patient having a complication. So what complications are common? Cardiac complications are the most common. They're the leading cause of perioperative complications in surgical patients of all age groups, but particularly amongst the elderly. And I didn't highlight it, but I am going to read parts of that last line. The combined effects of depletion of intravascular volume, age-related impairment of response to catecholamines, and increased myocardial relaxation time adversely affects the cardiac function of an elderly patient under stress in the perioperative period. So as patients age, they have a decrease in cardiac output, but dehydration is something that I think is undervalued in these patients. So it's not just their cardiac function, it's also their dehydration. When they get wheeled into the operating room and they get induced, anesthesia, puts the mask over their mouth, they give them some induction medications, they turn on the gases, they intubate the patient, they rapidly vasodilate. So anyone who is dehydrated is going to bottom out in terms of their vasodilation, their mean arterial pressures, and that's going to cause major issues in your patients who already have cardiac issues. So, and we come back to this conversation of the ability to increase cardiac output is really important, and with aging, that's dependent on ventricular dilatation, which again is dependent on preload. So all of these things go back to your first principles in your first year of medical school and Starling's law and all. It's all really important regardless of what specialty you end up in. Over one half of all postoperative deaths in elderly patients and over 10% or 11% of postoperative complications are a result of impaired cardiac function under physiological stress. And CHF is one thing that I want, to kind of call out because it is an important predictor of surgical outcomes. So managing that patient's CHF preoperatively, again, assuming that you have some time to do so, we're not talking about emergencies. I didn't include trauma and emergencies like that in this talk, but tweaking their management before they need to go to surgery is really important. CHF is present in about 10% of patients older than 65 and is the leading cause of postoperative morbidity and mortality. And it's going to go up. As patients get older and older, as our geriatric population grows and grows, we will see more and more of this. So highlights: careful attention must be paid to volume status in the perioperative period, and identify correctable and uncorrectable cardiovascular disease. That's important before you hand off to a surgical team and let them know what's active in this patient. Pulmonary complications. Again, another major source of morbidity and mortality. We know that they're going to have age-related changes as they get older. You have 50% of the capacity present at age 30. And you have that slow decline between 35 and 65, followed by this rapid decline at 75 and above. Risk factors for pulmonary complications include smoking, shortness of breath, COPD, all of the things that you already are acutely aware of. But knowing that this is also important when we intubate patients, and their ability to have nice, strong breaths when we try to extubate them is a predictor of how well they will stay extubated and not need to be reintubated emergently after surgery. So postoperative pulmonary complications, up to 50% of postoperative complications and about 20% of preventable deaths. Another thing that anesthesia is really good about is trying to find non-general anesthesia ways of sedating your patient. So having that conversation about, hey, are there any regional techniques that you might use? Is there anything that we can do where we don't have to actually put the patient under general anesthesia? Can we do a spinal? Can we do a beer block or one of these other blocks that anesthesia love to do? they're really good about it right now. I think there's been a huge explosion in terms of skill sets. So I don't think you need to get too much into it. I think they do a really, really good job, but please don't hesitate to bring that up as a question when you're sending your patients off to the anesthesia experts. And then quickly, renal complications dramatically increases morbidity and mortality. The mortality risk of perioperative renal failure in all patients is about 50%. About 50%, and might be higher in elderly patients. So that patient that you send off for a CT with contrast, and their creatinine bumps a little bit, and they're already a little bit dehydrated preoperatively, and then they have an abdominal condition, which leads to sequestration of 2 or 3 or 4 liters of fluid in their belly. Those are patients that are going to, and maybe they got a little vancomycin along the way. Those are the patients that leading into an operation are going to be of concern. So that contrast load plus dehydration plus other nephrotoxic medications. Even though there's a lot of literature that says you don't need to do a whole bunch of tests on patients before they have an operation, depending on what their physiological state is, checking an electrolyte panel on a patient that you think might need to go to surgery beforehand and helping correct some of those underlying electrolyte or fluid issues is important. So I'm going to go through the next few slides a little bit quick in terms from a time perspective. Functional evaluations, critical. You guys are already on top of this, but it's important to communicate that with the team as well. And we do this, again, we shake patients' hands, we look them in the eye, we talk to them, we watch them walk in and out of the office. We make surgical determinations based on what we see in that moment as well. And these are really good predictors of recovery after major surgery. Nutritional, sorry, I'm going to move forward. Nutritional status. This is what I want to spend a couple minutes on. And I could have put 10 slides on this, but I think I put just about 3. Oh, my apologies. I'm going to go right. So functional status. Let me finish up on functional status. We talked about what happens after surgery. If they can't get up, if they can't breathe, if they can't move, they're really going to lead to atelectasis, pneumonias, DVTs, PAs. Their pulmonary and cardiac complications are all tied to this. So assessing functional status before is important. What I would like to see is surgery get to the point where we have a full checklist for geriatric patients in terms of us assessing this in a detailed, scientific kind of way. I don't see us at that point as yet. This is where I think we need to be in terms of surgery departments. And the assistance that we get from the geriatrics team is immense, but this is where I think we're going to have to be in terms of surgery preoperative assessments, using tools and checklists such as these. A good bedtime reading, if you want to put something at your bedside and have some interesting reading about preoperative management, there's a good paper that came out that is put out from both the American College of Surgeons and the American Geriatric Society that is really good reading in terms of some of these ideas of preoperative tools and assessments. Cognitive impairment, as I mentioned, we assess that when we talk to patients because their postoperative confusion significantly affects when we can take their Foley out, how they can get up and move, if they can tell us they can use the bathroom. UTIs go up, 10% every day in the acute period for when a Foley is in. So we really want to avoid sepsis from UTIs and back to the issues of pneumonias, DVTs, and PEs. And then this is what I was rushing to, because this is really the important slide that I wanted to get to. Formal nutritional assessments. Get your dietitians involved before you send the patient off to the surgical consult, because a lot of patients, as you know, are malnourished. Up to 15% of patients above the age of 65, up to 50% in the acute inpatient hospital setting, and maybe up to 60% in chronic institutional settings. If they're nutritionally bankrupt, they're going to have really poor outcomes. A good marker of protein energy malnutrition is hypoalbuminemia. We check albumin levels. If a patient gets referred to us with a albumin of 2.8, anything less than 3, we're gonna not want to operate on this patient, even if it's something as simple as a umbilical hernia, because their risk of infection goes up significantly. Their risk of wound dehiscence goes up significantly. So if you have the time and you know you have a patient with an albumin of 2.8, and you have a week or two, uh, tell them, Mr. Smith, we're going to give you Boost milkshakes and Boost um, puddings, 3 times a day for the next 10 days. We really want you to eat this, because what happens is your 30-day mortality, your pulmonary complications, your reoperations, your length of stay all significantly increase. And severe hypoalbuminemia, as being described as anything less than 2.8. So 2.8 to 3.5 is moderate hypoalbuminemia by this study, is definitely going to affect postoperative complications. And I can put slide after slide after slide on this. I just want to throw this one in for the medical students to get really excited, because you got to throw at least one Kaplan-Meier graph in there. But we see it repeatedly that albumin levels, whether it's in-hospital mortality, out-of-hospital survivors, it's really going to affect things in terms of long-term complications. There we go again, from 5% in-hospital mortality to 14% between moderate and severe hypoalbuminemia. So correcting this early on, preoperatively, is critical in terms of getting your patients better. And then last couple slides, role of a surgeon, one line, call us. Call your surgeon when in doubt, get a surgical consult. So to the point where I'm actually going to go back to this slide and say, are we really doing enough surgical consults for patients who might have resectable lesions? Maybe, maybe not. The odds are we're probably not. And this is where I, for the purpose of this talk, I'm going to cross that line out and say, really, what's the role of the geriatrician? And yes, I did steal that that photo from the AGS, but the challenge for the geriatrician is, how can you help us improve perioperative care of the elderly using some of these new tools for patient selection, assessing risk factors, and communicating that and documenting that for the teams that are taking care of patients. So back to that long list of learning points that I thought, surgeons don't really have the capacity to digest so much, information in one go. I am going to read through these last 2 slides. Frailty, dementia, and geriatric syndromes have been identified as major factors in the development of postoperative complications in the elderly. Impaired cardiac function is responsible for more than a half of the postoperative deaths. So careful attention must be paid to intravascular volume in the preoperative, perioperative period. In elderly patients with acute appendicitis or cholecystitis, a third are going to lack a fever, a third are going to lack a white blood count elevation, and a third is going to have any findings of peritonitis. Remember, physiological age is important for us in terms of the major predictors for perioperative and, morbidity and mortality, and communicating that with the family as well in terms of having realistic goals and expectations is important. And then talk to us about laparoscopic approaches and regional blocks for surgery, because that's really the way we should be doing to reduce complications and ensuring rapid recovery. And then use some of these new tools and communicate these tools to your surgical colleagues so that geriatric syndromes and frailty indicators become more of a conversation piece. So that's it for me. A couple references in terms of what we use to pull this. That optimal perioperative management in the geriatric patient paper is really good to Google. You can find that online. And then just one plug in terms of checklists. If you have not read this book, please read the Checklist Manifesto by Atul Gawande. It's an excellent book that really talks about the importance of checklists in terms of patient safety. So I have less than a minute. I apologize for going over a little bit, but I'm happy to answer any questions.
Dr. Raman, thank you for a very informative session. We already have a couple of questions in our chat. The first one is from a fellow who's from New York, and he's asking, is it common for surgeons in Hawaii to require DNR patients to be full code for operative and perioperative periods. He's trying to compare what he saw in New York to Hawaii.
I don't know. I can try to find that out and get that information too, because I have not practiced as a surgeon in Hawaii, but again, the American College of Surgeons really pushed hard in 2014 to say, look, what are we doing? We really shouldn't be taking away patient autonomy and making this a hospital policy or a surgeon preference. It's usually a hospital policy that we remove the ability to have a DNR in the OR. So I know between 2014 and 2016 there was a lot of change in Oregon. Again, Oregon being very progressive, your West Coast, from everything that has to do with end of life care and autonomy. So in the Central Oregon area, we really got our hospitals away from that suspension of the DNR and the OR to the point where you have that required reconsideration. So I don't know what happens here, but I can make some inquiries and find out. I do have some anesthesia colleagues that I can reach out to. But I would be surprised if that still happens. That is not something that should be happening.
I do see some of our hospital geriatricians on the call. I see Yuka, Britta, maybe there are others there too. Do any of you have any comments about what you see in the hospital setting for patients who are usually DNR and during that perioperative period? Any comments from any of the geriatricians?
And I would think that in very, very rural parts of the country where you probably have a single sole surgeon who's been practicing for 35 years, and maybe they're not following their college guidelines and not reading articles, maybe that's probably the areas you're going to see that. But I know you guys are really good at advocating for your patients, and these geriatric patients are like family members to geriatricians. It's not like the orthopod where you come in, you fix a bone, and you run away. You guys have a really different relationship with your patients. So the reason I brought that up is just to make sure that's something that you advocate for. And I don't think it's going to be an issue in Hawaii, but maybe in some of the outer islands it might be still happening.
Okay, I don't hear from any of our geriatricians. They're muted still. But yeah, do you have any thoughts?
I think from, I guess, the inpatient perspective, it's not uncommon for my patients who are DNR, and we've talked about code status extensively. It's not uncommon for them to be switched over to a peri-op full the day of surgery that sometimes continues on for the next 1 to 2 days post-op. Every surgeon is a little different on what their comfortability is, but most of the time I notice that my patients are switched to peri-op full, but there is some sort of documentation by the surgeon saying that they've discussed the risks and benefits with the patient and our family.
And that's the key part. It's a required reconsideration. So if they talk to the patient and say, hey, we're going to give you some medications, it might cause an arrhythmia, it might cause some weird stuff to happen. I know you're DNR, but in the OR while this happens, are you okay with us giving you some medications or actually resuscitating you to bring you back through this procedure? And if the patient says okay, then I think that's totally fine and ethically okay. What I want you guys to be aware of is the fact that there might be some outliers that still do this automatic thing without having that full discussion with the patient, and making sure that the patients have autonomy in that moment. If they go, you know what, I'm good. If I die on the table, let me go. It should be respected. And if we're not doing that in these communities, then we all should be kind of gently pushing that 2014 American College of Surgeon paper quietly under the desk to maybe the chair of the departments to say, hey, can you guys look at this and see if the hospitals need to. I understand, and this is from my friends in the community, I understand that sometimes practice changes are hard in Hawaii, and sometimes maintaining standard of care sometimes are hard because of just generational things in terms of, we've always done it this way. So if that's the case, then maybe some of that needs to be a conversation. I'm happy to help if you all need some help pushing that conversation as well.
Thank you, Dr. Raman, and thank you, Dr. Aramaki, for your comment. That was very helpful. I don't see any other comments in the chat box. If anyone has questions, please type them in right now. Michaela has put the evaluation link in the chat box, so don't forget, if you want CME, you do have to do your evaluations to get your CME. If there are no more questions, we are a little bit over time. Dr. Raman, thank you so much for a very comprehensive and really interesting review on surgical considerations in older patients. It was very, very helpful.
Again, and I'm happy to give it. And again, I apologize for going over a little bit.
No problem. Thank you so much.
All
Okay,
right, thank you.
bye. Bye, everyone.